Late hour, thank you very much. These are my conflict of interest. I'm advisor board Panzer and Tables Hospital. That's not related. But related is I had a governmental funding with Bio-Impedance-Technology and Honoria from Medtronic and Baxter. Esophageal Doppler monitoring measures velocity of particles. For example, in the esophageal Doppler monitoring device, it's in the aorta descendens. You can measure it in the LVOT too, but I will pass that on to our next speaker, talking about echo. Here we measure stroke volume by the descending aortic flow. How we do that? They do a curve covering the flow, and then they determine the area under the curve, and they have a conversion factor in these ODM monitoring devices. The problem is this conversion factor might not be associated to the individual aortic dimensions, but on the other side, this offers us a possibility that we don't have to add additional measurements. So that's why it might be a good explanation why a nomogram based with age and weight and height has a very good association to the measured values by other methodologies. That's the background. And additionally, the Doppler measures corrected flow time as a measure of afterload I will further discuss. How you do, based on these monitoring device, how you do a goal-directed therapy. You do a testing, and this is something I want to pass on to you, that you ask the question, does stroke volume increase with fluid administration? You just do the testing, you do the intervention, and then you're measuring stroke volume before and after. Okay, you can say it's an old thing, but on the other side, you can do it with anything. You can do it with stroke volume, with blood pressure, with capillary refill time. You can this approach, the trial and error approach, to any patient, and this will help you individualize the therapy to the physiology of the patient. Why? Because the answer, how this physiological system reacts, offers you the principle of individualization of your therapy. If it's repeat the testing, if it's a successful one, and reject the hypothesis if it's a bad one. And this is really physiology, and this is the way we do it. Another point, if you're very expecting that the trial should be positive and you are nearly sure the patient should have a benefit, but you couldn't measure the benefit, then consider the limitations of the methodology. With that approach, you come far better to the individualizing your therapy than just using these standard values. And to provoke the auditorium, how you guide based on these values, your therapy. Miguel Indurain, he won 5 times the Tour de France. He was one of the weird guys. Resting heart rate 30, maximum cardiac output, that's my favorite, 47 liters. How to individualize in such a patient hemodynamic care, if you test him. How he's responding to your intervention. And would you give him atropine? I wouldn't do that. Diego Armando Maradona, these are my estimations, but you see he has completely different values, but he was a world-class athlete, but much lower than the first one. And again, what would you do if he's hypertension? Would you treat that hypertension in this patient? It's very difficult to answer these things. And just by the based values, it's very hard to individualize care. And it's not only inter-individual, it's intra-individual variation that further, puts you to the point that, based on these values, it's very hard to determine good care. So, and this is even the other end, very old lady. There we don't talk about the fat, but at that point, how to individualize care in her. Again, it's the testing. And that's the way we should do it, based on the Frank-Starling mechanism, and that's the way the pulse control methodology is used, and that's the way the Doppler methodology is used too. And after 200 cc, you have an increase in the first trial, and in the second trial, you don't see a further increase, then you stop. At that point, the patient is optimized, not maximized. You could further maximize stroke volume, but that's not the goal for the individualization of the therapy. Okay, so further algorithm parameters by the esophageal Doppler is the FTC. It's the corrected flow time. It's the systolic flow time corrected to a heart rate of 60, like the QT interval, yeah? And it's normal that it's 1/3 of the cardiac cycle. This is a very good afterload measurement parameter. But it's very used frequently in different studies using the esophageal Doppler, but it's an afterload parameter, and it's very hard to use it as a preload indicator to guide fluid therapy. So it's used, corrected flow time, it's a useful parameter, but it should not be used, in my opinion, for guiding fluid therapy. But additionally, you have peak velocities, that's the maximum velocity of erythrocytes down the aorta, and this is associated to the contractile state of the heart. That can be used to differentiate hypocontractile state to the normal cardiac function. And yeah, the Doppler offers the possibility to have differential diagnostics according to the different states, like a light echo differential diagnostic issue. How you do it in a daily practice? This is a patient 55 years old with pancreatic head resection, Whipple procedure, and he has arterial hypertension as a preceding disease and colonic resection. Standard anesthesia balanced with epidural, arterial and central venous license in place. This is the initial measurement, okay? And this is something you see frequently after induction of anesthesia. You have a cardiac index of only 1. So do a testing, the first measurement 34, then you do a second one. We had in that case a substantial increase of stroke volume, so the patient had a benefit. I did a second trial, and at that point the patient turned negative, no more stroke volume increase. And then based on the physiology, we can come back to our normal values because stroke volume is individualized. Everybody has his own Frank-Starling curve, but still this cardiac index might be too low. So in this case, I just established epinephrine to further increase stroke volume, but in this individual case, and it worked out. This is an example how you use, based on Doppler measurements, an algorithm, how you drive therapy based on this methodology. How's the literature? The same study Professor Michard presented. It's a meta-analysis, a big study indicating that patients with high risk and with a high-risk surgical procedure and patient high risk have a benefit of advanced hemodynamic monitoring device. And there you see that the biggest chunk of studies are performed for the esophageal Doppler in the literature, but the outcome in this meta-analysis is negative. But how is it? This is purely directed to improve mortality. So this was a mortality-driven meta-analysis. And if you look at the studies from the esophageal Doppler, they simply didn't have mortality in their study population, so there was no room for improvement, so they couldn't improve mortality. But on the other side, if you look at the complication rates, they could, in this meta-analysis we published in 2016, there was a substantial reduction in complications by the esophageal Doppler monitoring. So the evidence is quite good, and in this study we published a number needed to treat of 6 patients to reduce 1 complication. Further, the last multi-center trial being positive in the field of hemodynamic care, as far as I know, is the Fioradora trial we published with many colleagues from Spain. There was, within an ERAS protocol, the esophageal Doppler therapy is still able to reduce complication. So there is evidence there, there's evidence there to use it, and that's the esophageal Doppler monitoring. Passing on to Bio-Impedance Technology. What is the Bio-Impedance Technology doing? It's sending a current through the thorax, and it measures the modification by the orientation of the blood cells on that current, on the way it goes through the thorax. And it is dependent on the flow, and during flow states, the erythrocytes align according to the flow, and in non-flowing states, it gets diffuse and chaotic. And deriving parameters from these flow measurements brings up the stroke volume and different hemodynamic parameters associated to cardiac function and to volume status. We did a study we have now under review. What we did is the individualization. Professor Michard showed us by the study of Bernd Saugel and the fatigue study that we need perhaps in the future preoperative measurements of our patients to individualize our care. And this is with such a bioimpedance technology very easily possible. What we did prior to the day of surgery, we measured the hemodynamic status for 20 minutes, laying down in bed. And then we compared that with the first measurements during surgery, after induction of anesthesia. And what you could see, like the study of Bernd Saugel suggested, we have a substantial decrease of heart rate, we have a significant decrease of stroke volume, and we have a significant decrease on top by the index of contractility, an inotropic marker. If we take now this first measurement as our baseline, we wrongly direct our therapy. We have to go back to the measurements prior to the surgery. And this is something offered by this methodology to perhaps in the future better assess our patients. The interesting point was that for me, as I can tell you, perhaps I'm a bad anesthetist, but for me, during surgery, the heart rate maintained lower than the previous preoperative values, and after surgery it was statistically significant increased. So we have a certain pattern of patients undergoing the perioperative pathway, and this was based on no alterations of stroke volumes during the perioperative course. But this was based on our fluid administration, mirrored by this graph, where we could show that already with the first measurements, we have an increase of thoracic fluid content as a fluid measurements in the tissue of the thorax, and this maintained up to the third postoperative day. And further interesting for me was that the index of contractility as a contractile marker of the myocardium was maintained, reduced throughout the whole surgery. And this is really interesting because these were very healthy patients. Yeah, they were cardiovascularly healthy. So it can be just by our anesthesia and just by our opening up the abdominal cavity. Interestingly, when we compared, it's a small study, observational study, then you can see that there was no difference in stroke volume between patients with complications and with no complications. But if you look especially, then you see that postoperatively we had a difference, a statistical difference in stroke volume between patients with and without complications, further bringing up the issue that we should go on measuring after surgery and should we go on monitoring these patients perhaps in the future. Another technology is the Bioreactance Technology. They measure, based on the Bio-Impedance Technology, different parameters, and what they do is that they offer you cardiac output, stroke volume, the variability, and afterload parameters to optimize your care. And the same thing applies for that monitoring because they do the Starling optimization. They called it the Starling monitor, but it's the stroke volume measurement prior to a trial and then thereafter to confirm if a patient improves hemodynamically by that trial. Published is such an algorithm for the Starling algorithm by Professor Douglas, in chest in septic patients. They did a passive leg raising test in early septic patients, and according to the stroke volume change measured in this monitoring device, they did the vasopressor intervention or they did the fluid intervention, and they could, okay. Then I have to state the differences. The primary outcome was positive. There was a reduction in fluid administered in the first 72 hours. And additionally, they could reduce the number of renal replacement therapy in this trial by administering the fluid guided based on that monitoring device. This is a daily example from our PACU recovery area where after being fluid optimized, I extubated the patient, went to the PACU area, and there I had I reassessed the patient. I recognized there was a stroke volume decrease, and at that point I restarted the fluid administration and had substantial benefits after surgery. Perhaps this might be the future, that we individualize care in the whole perioperative context based on such non-invasive monitoring devices. Thank you very much.